So hello everybody. Everything's okay? I had a lot of pumpkin pie and turkey. It's Thanksgiving. And I'm a bit, today I'm a bit, I'm not so, not eager enough. So, well, we'll go on with glomerular diseases cases, but first I must correct a mistake. I saw that kidney at the bottom and told you that it was a rejected transplant. No, I was not right. Of course, if we have a transplant rejection, it looks like that. However, it's not the case here. It is an infarct, a very big one, infarct of the kidney, because the renal artery was thrombosed. And it looked strange to me because the patient was taking heparin, which is for exactly the opposite. However, as you have studied, there are some autoantibodies being developed, and that causes a prothrombotic state. So it's heparin-induced thrombocytopenia, and that's a complication of venous thrombosis. So both of these kidneys are the patient's kidneys, and they both have nephrosclerosis, that meaning hyaline arteriolosclerosis. Not a thyromatic disease, hyaline arteriosclerosis. So let's go to the kidney diseases. We said some terminology when we finished our lessons, and now let's have a look at the kidney. The glomerular, you see here, have a look. What part of the glomerular is this? It's the supportive tissue known as mesangium, all right? Here are the intraglomerular capillary loops, and here are the lumen. So what do we see? First, we have to judge. Are there any hypercellular areas? Are there any hypocellular areas? That means if we find more cells than normal, where are they? Are they in the, pay attention, it's a bit difficult today, pay attention. Are they, I'll make it as simple as possible. Are they in the intracapillary compartment? That means, what's the intracapillary compartment? The one that it's the intraglomerular capillaries. That means endothelial cells and blood cells, white blood cells. This is intracapillary hyperplasia. So how can you see that in the section? There is no lumen. Why? Because there are cells filling the lumen and you see no lumen. Next, are there many cells in the mesangium? This is mesangial hyperplasia, which is most often accompanied by an extension of the mesangium. And these two patterns of hyperplasia commonly coexist. That means mesangium is in direct contact with the intracapillary compartment of the glomerulus, because the basement membrane through which blood passes and becomes urine is not full in the lumen. It goes directly to the mesangium. So anything that affects the subendothelial place, that means the intracapillary compartment, can have access to the mesangium matrix as well. These two compartments communicate with each other because the glomerular basement membrane is not full throughout the lumen. So these are two kinds of hyperplasia. There is another one that we have hyperplasia of epithelial cells. Where are epithelial cells in the glomerulus? They are mainly in the lining cells of Bowman's, what's this? Bowman's capsule. And this is the one layer of epithelial cells, and the other one is the podocytes, which are located on the outer surface of the glomerular basement membrane. So this is the extracapillary compartment of the glomerulus. When we see many cells there with, of epithelial origin, we identify crescents formation. So now, and of course there are some other cases that we have hypocellular areas. That means either sclerosis, highlighted by Masson trichrome stain, either amyloidosis, highlighted by Congo red stain, or necrosis, which stains red in trichromation. So these are the main causes of hypocellularity within the glomerulus. So we said hypercellularity, and where the many cells are, hypocellularity, and where these areas are and how they are justified. And the other thing we have to look at is the configuration of the basement membranes. Are they somehow thickened? That's all from morphology, okay? So from all this we've already talked. What do you think we see here? Is there an intracapillary hyperplasia? No, because all lumen are open. No. Is there extracapillary hyperplasia? No. Look at the urinary space. No cells here. Fine. However, there are some areas where the mesangium is expanded, and we count more than 3 cells, 3 mesangial cells, but pay attention, away from the vascular pole of the glomerulus, where the efferent arteriolus goes and the afferent leaves. If I say it right, I'm not so sure, the afferent and the efferent. That's okay. You understood what I say. So have a look here at this area. Let's count. We have an expansion of mesangial matrix highlighted by pus stain here. 1, 2, 3, 4, 5, 6. This is mesangial hyperplasia, not accompanied by intracapillary hyperplasia. Why? Because we see the lumens are open of the capillaries. And this is a morphological pattern which is most consistent with the most frequent glomerulopathy, which is IgA nephropathy. This is an immune-mediated glomerulopathy, and clinically it appears some days after an infection, either of the gastrointestinal tract or the respiratory tract. What does the patient do? He sees that his urine becomes red. Then it vanishes, the symptom vanishes, and after some time it relapses. The urine is red again. So, where's my coffee? This is the one. Do not take the other one. So, this is a clinical symptom of recurrent hematuria, which is consistent with IgA disease. And since it is of immunocomplex mediated, we have to have positive IgA immunostaining in immunofluorescence. And it should be, so that it is specific for the disease, granular. This is how immunocomplexes appear in immunofluorescence, and diffuse. Not just in a part, not segmental, because this is most probably an entrapment of staining, not specific. To see that it is immune complex mediated glomerulopathy, the signal of the immunofluorescence should be granular, diffuse, and global. What does this mean? If we see these areas in the immunofluorescences, all immune complexes should be here, 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 here. This is consistent with IgA nephropathy. So, to diagnose IgA nephropathy, immunofluorescence is mandatory to be positive for IgA. Morphology is not enough. The most common pattern is this one of mesangial hypercellularity. However, it's not the only one. And let me stress that to make a safe diagnosis of glomerular diseases, you have to take into account both morphology, immunofluorescence, and possibly electron microscopy, which will highlight, the latter will highlight the immune complexes deposition in these areas of the mesangium. And in order to suspect that we have a glomerulopathy, we look at the shape of the red bloods which appear in the urine. If the red blood cells are of glomerular origin, that means they have to do with a glomerular disease, they are somehow dysmorphic. And this is not the most common, of course, finding, because if you have hematuria, what's the first thing that you will think of? Not a glomerular disease. What will you think? Either a neoplasm somewhere in the urinary tract, or from the kidney invading the urinary tract, or a stone that moves and erodes the urothelial mucosa. These are the first you think. But when you exclude these causes, have a look at the shape of the red blood cells in the urine. If they are somehow compressed, they might be of glomerular origin. So you have to make a renal biopsy and study the glomeruli. So that was IgA nephropathy, with the most common morphologic pattern of mesangial hypercellularity. And you see the prognosis, there are some factors making it worse, here it is. You see? You see the selective deposition of IgA immunoglobulin in the areas of the mesangium where we saw the increased number of cells. And pay attention that the pattern is granular. There are small, small granules. This is highly specific for immunocomplexes deposition, immune depositions. That's the correct image. And because since morphology is preserved, you can see the depositions. Where are they? Are they throughout the basement membranes? That's another pattern. Are they in the mesangium? Like here, that's another pattern. But I stress again that in order that the findings of the immunofluorescence are diagnostic of a glomerulopathy, they should be granular, like here. There is only one exception in anti-GBM disease when they are linear depositions. That's an exception. And they should be diffuse and global in more than half of the glomeruli, and in the affected glomeruli in more than half of their volume. Okay, so these are IgA deposits, and the main clinical symptom of the patient is, this is a henoch-Schönlein purpura with arthralgias. What is this? In contrast to the previous case, when we had primary glomerulopathy, that means a disease starting from the kidney, from the glomeruli. This is secondary glomerulopathy, IgA again, because there is a systematic disease which affects the renal parenchyma, and the damage starts from the glomeruli. That means it is a glomerulopathy, but it accompanies a systemic disease. And the systemic disease is henoch-Schönlein purpura. So, in this case, we find IgA depositions, like the previous case, but This is a secondary glomerular disease.
How do you differentiate?
From strictly a histological point of view, it is indistinguishable. But as always, you take into account the patient's history, symptoms, and findings. Because if you look at, if you tell me, what do you see? I say, I see depositions, diffuse, global, granular. It's IgA nephropathy. No, because there is it does not correlate with the findings here. Arthralgias, you see?
We don't ask.
It's a whole consideration. Patient symptoms. Have I told you the clinical patterns of glomerulopathies, the clinical findings? Did I say that the previous time? I don't think so. I'll say it now. One syndrome, clinical, from a clinical point of view now, is if there is heavy loss of protein, the urine. There is very severe proteinuria. That means it exceeds the value of 3.5 millimeters per day. So what is the consequence if we have such a significant loss of protein, of albumin? The oncotic pressure becomes low, and we have edemas of the nephrotic syndrome. That's one clinical symptom related to glomerulopathies, the nephrotic syndrome. Severe proteinuria is the main finding. Another now. We have hematuria, mainly hematuria, which lives and comes. Lives and comes. That's the one we said in IgA nephropathy. So the other clinical syndrome is recurrent hematuria, mainly. The next one is some degree of proteinuria, not in the range of nephrotic syndrome, less proteinuria than that. Some degree of hematuria, some degree of hypertension due to an increase in the volume of blood because it is accompanied with oliguria. You don't produce enough urine, so the intravascular blood volume is increased. And this may cause hypertension. Of course, there are other mechanisms, as we have previously discussed, that cause hypertension in a patient with renal disease. One of them is that this is within the context of nephritic syndrome. Nephritic syndrome. And the last syndrome is a significant increase of creatinine levels. That means a quick establishment of renal failure in a patient in which a nephritic syndrome was first diagnosed. So it is not a mere nephritic syndrome, as we described it previously, but it affects the values of creatinine. Within 2 or 3 weeks, you see a creatinine of 2.5, 3. This quick increase in creatinine levels is consistent with rapidly progressing glomerulopathy. And we'll see the histological background of this syndrome. But up till now, we saw the syndrome, the clinical syndrome of recurrent hematuria, which was consistent with IgA nephropathy. What's the difference here between this case and the previous one? Are there many cells in the glomerulus? Yes, there are many cells. However, what is different between this hypercellularity and the previous one? What is different? Yes? It's not. To see if it is diffuse, you have to see all the glomeruli. If you see one, you don't know if it is diffuse or focal, because you see one glomerulus. If all the glomeruli look like this, it's a diffuse lesion. You wanted to say if it is global or segmented. That's what you meant. I think that it is a global lesion that affects the glomerulus involved throughout. There are many cells again, but there is something you do not see here that you saw in the previous glomerulus. Have a look at the previous morphology. This hypercellularity was solely where? That was solely mesangial. Whereas the other one is both mesangial and excellent, and intracapillary. That's why we don't see the lumen. We don't see the lumen of the capillaries, because there are many cells both within the capillaries lumen as well as in the mesangium. So, yes?
You said before that for an IgA neuropathy we need to have global, but isn't it
always for an immune?
segmental?
Yes, but yes, no, it's within mesangial areas throughout the glomerulus.
Global in the context of mesangial cells.
Yes, global in the context of the cells being affected, not just in one side of mesangium, in all sides of mesangium. This is global.
Okay.
So, this is also an immune-mediated glomerulonephritis. So, what do we expect in the immunofluorescence? Granular deposits. However, not predominantly of IgA in this disease, mainly of IgG and C3, because have a look at the history. 3 weeks after an episode of pharyngitis. This is post-infectious glomerulonephritis, which in the present case has given hematuria and proteinuria. So it looks like a nephritic syndrome, and we have this biopsy, see the cellularity. So what do we expect so that diagnosis is confirmed? We expect the granular IgG depositions in the affected areas, in the affected glomeruli. So this is another immune complex mediated, and in this case I won't show you the immunofluorescence, I'll show you the electron microscope image. All those humps that are round, dark structures are immune deposits. So now, where are they? Let me help you a bit. Look, this is the capillary. That's right. This is the capillary. You see, this is the glomerular basement membrane. You see these humps? Where are they close? Are they close to the endothelial cell looking the lumen, or are they close to the podocyte, the epithelial? Have a look, a careful look at the basement membrane. This is the outer surface of the glomerular basement membrane. This is the inner surface. So this nucleus probably belongs to an endothelial cell because it looks at the lumen. So these deposits are close to the inner surface of the glomerular basement membrane. This is the outer surface, you see? This is the basement membrane. It goes close to the lumen, not to the outer where the podocyte is. It goes close to the endothelial cell. This is the endothelial cell. The nucleus belongs to an endothelial cell. Okay? So, these are subendothelial deposits of IgG. And why is this important? Because next we'll see another immune-mediated glomerulopathy, membranous glomerulopathy. It will have deposits, but they will be subepithelial. What does this mean? This is the lumen of the capillary. This is the podocyte. What is under the foot processes of the podocytes is subepithelial. What is close to the lumen and under the endothelial cell lining the intima of the capillary is subendothelial. Okay? And of course, we have the clinical correlation with the nephritic syndrome. So those were the humps of post-infectious glomerulonephritis.
These are IgG deposits?
IgG, yes, IgG. And let me correct myself. It says subepithelial, so I'm not good at electron microscopy. In this case, they would be the same as the membranous, because in membranous glomerulopathy, they are also subepithelial. So how would you discriminate with the clinical symptoms? You see that one thing is not enough, and you should always correlate everything. So let us make it clear. This is close to the epithelial surface here. However, I'm not sure I see the foot processes. But sometimes you take into account the configuration of the immune deposits. Now that it is like a nodule, a small nodule round, it is most consistent with post-infectious glomerulonephritis. Okay?
Professor,
Yes.
isn't this a podocyte and you have next to the podocytes?
Which is the podocyte? As I read the image, I thought, let me tell you what I thought and why I was wrong. I thought, this is the podocyte here. You see this one? You see the foot processes? Have a look. Here. Now, if this is an immune deposit, you see here, it's close to the podocyte. You see? You see that this is the podocyte. Do you all see the foot processes? So if the immune deposit is close to the foot processes, it's subepithelial, close to the podocytes. However, in this case, with this arrow, I think that this is the lumen. Let me check. Yes, it's the capillary lumen. And I thought that this immune deposit is close to the lumen. That's why I told you it was subendothelial. So I wasn't totally wrong. Because look, this is the lumen, okay? Let's check. And it is filled with a leukocyte. So this is not an endothelial cell. It's a leukocyte. Because it's blood. It's cell from the blood. White blood cell. So I saw this being close to the lumen, and I thought, logically I think, that it was subendothelial. However, in other areas, it was much more close to the foot processes of the podocytes, thus subepithelial. Okay, I know you must have experience in reading the electron microscope. Okay? At least let's understand it in theory, and sometimes all of you who will become nephropathologists will have an expertise on. Yes, please.
You said also for subepithelial and subendothelial.
Yes.
You can also see the clinical features.
The clinical features, yes, because subepithelial deposits occur in membranous glomerulopathy as well. However, membranous glomerulopathy is related with nephrotic syndrome. What is nephrotic syndrome? Severe loss of protein. In contrast, post-infectious glomerulonephritis is related with nephritic syndrome, another clinical syndrome. Okay? You always take the clinical features into account. Here we are. Now, do you see increased cellularity in these glomerulus? And where are the increased cells? Are they within the lumen? Are they in the mesangium or are they extracapillary? Or is there extracapillary proliferation? What do you think? Extracapillary, and they form a crescent. So this part, this is the crescent. You see? Like the half moon. Yes. The half moon, this is the crescent. So, what is this morphological feature consistent with a clinical feature? This is the rapidly progressing glomerulonephritis. You remember we said that the creatinine values are severely increased in a few time. The histologic background of this finding is the formation of crescents. And when we have crescentic glomerulonephritis, that means extracapillary hypercellularity, we think of three possibilities. Three. One of them is the ANCA-related glomerulonephritis, which has to do with polyangiitis and granulomatosis, Churg-Strauss syndrome. It has to do with ANCA autoantibodies against some constituents in the cytoplasm of neutrophils. Crescentic glomerulonephritis, ANCA-associated. In this case, paradoxically, there is no immunofluorescence. They are posi-immune glomerulonephritis. Why? It's not logical because there are autoantibodies, but for some reason, they are not detected histologically. So, one form of rapidly progressing glomerulonephritis with crescent formation in more than 50% of the examined glomeruli. One possibility is ANCA-related glomerulonephritis. Another possibility is anti-GBM, anti-glomerular basement membrane disease. Which is the characteristic feature of anti-GBM? A linear deposition, not granular, linear deposition of IgG with a global and diffuse pattern in the affected glomeruli. And the last possibility behind rapidly progressing crescentic glomerulonephritis is another immune complex glomerulonephritis with granular depositions in immunofluorescence, such as post-infectious, such as IgA, which have been transformed to crescentic. So, when we have a severe deterioration in the patient's renal function, we look for crescents in histology. They are consistent with this, and then we have to judge the immunofluorescence findings. If it is posi-immune, there is no immunofluorescence depositions. This is ANCA-related glomerulonephritis. If we have a linear, not granular, linear deposition of IgG, is anti-GBM. And if we have granular deposition, is one immune-mediated, immunocomplex-mediated glomerulonephritis, which has been transformed into crescentic glomerulonephritis. So what was the case here? The case here is, let's see, a case of ANCA related with granulomatosis with polyangiitis. What pattern is this? What staining pattern is this? There is positivity in immunofluorescence, okay? So it's not ANCA related here. This case is not ANCA related. It's linear. What is this consistent with? Anti-GBM. And if the lung capillaries are also affected, we talk of good pastures syndrome. Okay? Yes?
I'm confused. With ANKA, we don't see anything on
Nothing,
the image.
nothing.
Are there no depositions of...
There should be, but we don't see them because ANKA is autoantibodies. However, they are not located in the tissue.
Why?
Ask them, I don't know. I don't know.
How are the cells affected then? I don't
You'll try and find it. It's too complex for me to get into the mechanisms, into the pathogenetic mechanisms of all glomerulopathies. However, it's a logical question because since there are autoantibodies, why are they not discernible? They are not recognized, they are not identified by immunofluorescence. Here they are, and this is anti-GBM disease with a linear deposition, okay? Here, is there increased cellularity in this glomerulus? No. So the glomerulus is normocellular with the correct number of cells. However, we have clinical findings of nephrotic syndrome, that means severe proteinuria, and we have a diffuse and global lesion. Can you identify it? It's the thickening of the basement membranes due to immune complexes deposition. And when you have silver stain, you see that as parts of the basement membranes are compressed by the immune complexes, they become like, how is that now? This is what they become like. Have a look here. This. You see these small lines here? What are these? These are parts of the basement membrane which stains black in silver stain, which are compressed by the immune complexes. Let me see how this is called. Black projections. Yes, here they are. Black projections. You see? This is consistent with membranous. You don't see achides. They are like if you cut a rose, the flower. Thorns, yes, something like that. Okay? These are not the immune complexes themselves. These are parts of the basement membrane which is compressed by the immunoglobulin deposition and becomes like that, like a projection. Yes, this is it. And it is, basement membrane is highlighted by silver stain. Yes? They're not cells affected. The cells are normal in number. There are depositions of immune complexes throughout the basement membranes. This is the stage 2 of membranous nephropathy. Here we do not have increased cells, as in the previous cases. The glomerulus is normocellular. However, there is an abnormality. You remember what I told you? We look in the glomeruli. If there are increased cells and where they are, if there are reduced cells, and what does this mean? And if the basement membranes are thickened. This is the case, where the basement membranes are thickened.
The blood flows inwards, as we see it here, right?
Yes.
Goes inside. So
Yes.
the depositions must be from inside to the outside.
In membranous glomerulopathy, the depositions are subepithelial, like post-infectious. However, they are differentiated due to the clinical symptoms. Okay? So, and membranous glomerulopathy could be either primary, starting from the kidney and the glomeruli, or secondary. That means you have a malignant neoplasm someplace, you see, and infectious diseases. You see, melanomas, lung cancers, colon cancers, hepatitis B, and you have a systemic disease, and the kidneys, glomeruli are affected, and they become like that. This is membranous glomerulonephritis secondary to something else that is in the body.
Can it
Of course it is, because if it is related with these cancers, it can have the features of a paraneoplastic syndrome. Yes, that's right. Now, here, look, this should be, now this is clear. We'll understand that. These are the immune deposits by electron microscopy. So, who can come and show me where the food processes are, where the endothelial surface is? You come. You come. Yes, because you study the mechanisms very meticulously, so I want you to have the practice. So sit right here. So show us the food processes. What are the food processes of the podocyte? Yes. What can they be, the food processes? Because this is the outer surface. This one. Look, have a look at all these. You see here? All this? These are the food processes. You see? The podocytes are here. You see these immune deposits? And what can this be? This is the endothelial surface. The lumen of the capillary. So, where are they close? Are they close to the endothelium? To the podocytes. That's why they are called subepithelial. They were the same this was the same location as in post-infectious, that I got confused. However, there, they were more round. Want to show them? To remember? So, these are the immune deposits of membranous glomerulopathy. Let's have a look at the... Here they are. You see, they are different. These are called humps. Immune deposits as well. IgG as well. C3 as well. But in a different clinical context.
In the other one, the membrane seems more thickened as well.
Show me, what do you mean?
The membrane itself looks more thickened in the other.
Where the immune deposits are.
Yeah, but
in the other, in the membranous, they are more diffusely thickened. Because here that we have the post-infectious, it's an interesting difference. In post-infectious glomerulonephritis, the glomerulus was hypercellular. Why? Because there were many cells within the vessels. Have a look at histology. Does this look like membranous? No. This is a proliferative glomerulonephritis. Why? Because there are many cells. Either intracapillary, in the intracapillary compartment, or in the mesangium as well. And the last case we'll see, shouldn't have it in all this pumpkin pie. Shouldn't have done that. It affected the what I say in the lesson today. It affected the lesson. Yes, shouldn't have done that. So, oh no, what? So, tell me, are there any immune deposits in this electron photograph? You remember how the immune deposits look? They are like dark humps in the post-infectious or more irregular. Are there any immune deposits here? What do you think? Because I don't see anything. The basement membranes are clear. Okay? You want me to show you the immune deposits to make the comparison? With pleasure. Because this is one of the things I know. So, here they are. These are the immune deposits. You see here? All these. Are there anything like this here? No. What's the problem here? This is a podocytopathy. That means that the food processes of the podocytes that we have seen in previous images are effaced. So the result is proteinuria, severe proteinuria. However, this is not immune mediated. This is not an immune complex deposition. So the immunofluorescence should be negative or non-specific. That means some parts are entrapped of some immunoglobulins. No, to diagnose immune-mediated glomerulopathy, you remember the sign should be global, not segmental. If you see segmental sign in immunofluorescence, it may not be, it's not specific. It's entrapment. Yes. And the podocytopathies are two entities, minimal change disease, mainly in children, and it automatically reversible, and the other one we'll see next. So, yes?
Here, the podocytes are where? In this side?
They should be there, yes. This would be the urinary space, I think. Yes.
And this is a red blood cell, for example?
Probably, yes. Okay. Probably. Yes? Want to ask me something? Yes?
What is a black
Red blood cell.
A red blood cell. Yes?
Are any podocytes visible here?
I'm not sure. Ah, there are some. There are some. I think here. There are a few. You see these? You do not see all those food processes that we saw in the previous images. They are affected. So if they've completely vanished or there are some remnants. So this is minimal change disease in children. And have a look here. We have Masson stain, and it stains a part of the glomerulus. So what does Masson trichome stain? Connective tissue. So this is sclerosis. Does it affect all the glomerulus? Because I had too much pumpkin pie and I cannot go to buy the Black Friday offers. That's what happened to me. And have no reason for existence anymore. No. So what were we saying? So I want you, no, you cannot go, it's 1 o'clock, no, you stay here. Because you 2 minutes. So, tell me, there is a lesion, there is a sclerosis. Okay. It affects only how many glomeruli does it affect? One, and I'm not sure here what's happening here. However, it affects less than half of the glomeruli in the biopsy. So, how is this lesion termed? A focal. In the affected glomerulus, is it affected throughout? Is it global? Have a look. No, this is the normal. The abnormal is the blue is the abnormal. You look very... No, this is the one. This is the lesion. It's less than 50%. You see? This one. Don't look too meticulous. You are good in electron microscopy. No, this is conventional light microscopy is here.
So there should be some connective tissue, but
yeah, but not increased. Yes, not sclerosis like there. So how shall we term this? Focal segmental. This is focal segmental glomerulosclerosis. However, a cause of nephrotic syndrome, severe proteinuria. However, if you have fluorescence and it is strongly IgA positive, it isn't focal segmental glomerulosclerosis. Immunofluorescence wins. It's an IgA nephropathy which took the morphology of focal segmental glomerulosclerosis. Thus, the diagnosis of focal segmental glomerulosclerosis is a diagnosis by exclusion. You must have negative or non-specific immunofluorescence and this pattern of sclerosis in less than half of the examined glomeruli. So that was the podocytopathy. And as you can see in the next, here is another pattern of sclerosis, very common in diabetic patients. Nodular glomerulosclerosis. You see that the sclerotic tissue forms a nodule? And it's better for us to see diabetic nephropathy on Monday because it's significant. So that's all for today. Have a nice weekend.